I'm speaking today with Dr. Milan Somborac, who's a general dentist in Collingwood, Ontario, and he's going to demonstrate to us his solution to an everyday clinical problem that every dentist in Canada can identify with. What's the problem that you've come up with a solution for?
The problem is a universal one which patients appreciate or feel more than we do, and that is the feeling of numbness after local anesthetic administration. They want to be able to go out for lunch, for dinner, to speak to friends, and they can't do it effectively for 1 to 5 hours after an appointment, depending on the type of anesthetic that we use. So that's one of the problems. And the other one is we often miss local anesthetic and fail to get the effect that we want. So I have a solution for that by administering local anesthetic directly into patient's bone, which gets around the numbness feeling and which provides better results for getting anesthetic effects.
So, there's been intraosseous anesthesia before. What's so new about your technique?
The intraosseous anesthesia that exists now, and there are two systems. One is called the X-tip, the other one is called the Stabident. They are used in a slow handpiece, which makes it difficult to introduce them through dense cortical bone of the mandible, particularly through the external oblique ridge. And so they're a problem. They're not widely used because of that. They've always been a backup solution for inflamed pulps where local anesthetic effect doesn't work often because of the inflammation there. So endodontists and dentists doing endodontics go through the intraosseous route. I have a much easier access to intraosseous anesthesia with a system that I've developed through trial and error.
And let's have a look at it.
So I'm going to demonstrate the Collingwood intraosseous local anesthesia system technique. This shows some local anesthesia being introduced into the interdental papilla of the upper right first molar, second bicuspid. We're going to do a root canal treatment on that first molar. So we put some local anesthetic into the papilla. The local anesthetic has a vasoconstrictor in it, usually epinephrine, to minimize bleeding there. So all we need is a drop or two of local anesthetic there. Then we take an extra long Fisher burr, surgical burr, and go through the papilla and into the bone, into the cancellous bone to a depth of 10 millimeters or so, which then creates a channel allowing us to go in with that short needle, 30 gauge needle, using local anesthetic without epinephrine, because this is really an intravascular administration. So we don't want any epinephrine in there. And so we typically use carbocaine, and we deliver half a carpule, a full carpule there slowly. Patients don't feel it. If we touch the periodontal ligament of an adjacent tooth, they can feel it, but the discomfort is not excessive. So after we get the local anesthetic in place, it's effective almost immediately, no waiting allowed. What you see here is a couple of rubber dam stoppers. If we can't put that short needle in all the way, we sometimes get some backwash. We don't know how much local anesthetic went into the cancellous bone and how much leaked out. So these rubber stoppers prevent leakage. And when that's completed, this slide shows the target area. These red dots show where we want to be with our channel creation to get into the cancellous bone. And once we are in there, we can start our procedure. So we use this Collingwood intraosseous local anesthesia for 100 consecutively treated patients for every procedure that needed local anesthetic. So we did all these procedures as the patients came in one after another. We didn't have any selection process. We simply did them sequentially. We had an 89% success rate in upper and lower arches. That is, nothing additional was required in these 100 patients. And 11 of them, that is an 11% failure rate, needed some additional anesthesia. So what we're doing here, we're reversing the usual process of try a mandibular block or infiltration. It fails, you go intraosseous That's the way it's conventionally done. We start with intraosseous, and 11% of the time we weren't able to do it, which is a higher success rate than the literature reports for mandibular blocks, for infiltration into inflamed areas, for ligament anesthesia. This is an example of what the Gao-Gates injection technique comes up with articaine, the maxillary region, irreversible pulpitis, 87.5%. We were at 89. And so it's more effective. But the big thing here is patients don't feel anesthetized because no soft tissue anesthesia takes place. People don't have their nose anesthetized, an upper lip, lower eyelid, tongue, and they can go and carry on their social functions without the aggravation of being frozen where they don't want to be frozen. So this is the patient response that we experienced of the 89 patients with whom we had total success, who required no additional anesthesia. 2 patients had no previous experience with local, so they couldn't make a comparison. 2 patients said, feels pretty well the same. Interestingly, 2 patients preferred being frozen, and 83 patients were just so pleased to feel no sense of numbness in their face anywhere, so that they could then go and carry on with their duties without being handicapped by having a frozen face. So that overcomes a major problem which we in dentistry live with. You know, there's a product called Auraverse, which is administers medication that dilates blood vessels to rinse away or take away the local anesthetic a little faster. But it still takes 20 minutes or longer. Not needed with this method. So a conclusion that I reach from these cases, of a sample of 100, is that this is worthy of a trial in any dental office.
Well, thank you very much, Milan, for showing us your technique. And are you open to practitioners sending you questions, comments, observations, and suggestions?
Well, more than that, yes. First of all, absolutely. Secondly, I would like to see this study of mine, which is 100 patients, not a very large number of patients, done by some guy in general practice in a town like Collingwood. Nobody has heard of it. I'd like to see some university undertake this to give it the legitimacy that I feel it deserves. It's my primary method of local anesthesia now in the office for just every procedure. Now, that's the first step almost all the time.
Fair enough.
Yes, I'm open to listening to anybody, and if there's anybody out there looking for a project for graduate students, this would be a great one.
Yeah. Well, this presentation is what we call a conversation opener, and we invite colleagues in practice, in general practice, specialty practice, and in the university and research settings to enter the conversation. So
to make it even easier, John, I answer my phone 24/7. They're welcome to call me at 3 in the morning if they want to talk about this subject.
So we'll have your practice website and your email address and your telephone, that 24/7 telephone. Yeah, they might take you up on that. Associated with this post in Oasis.
Thank you.